Chronic myeloid leukemia, which is what we're studying, we know it's caused by a single genetic lesion, and this is the BCR-ABL fusion. But we know that from next generation sequencing assays that have been done over about the last decade, that we've started to find additional variants in myeloid or lymphoid genes, and they're also detected in other hematologic malignancies. So some of these genes appear to be associated with disease progression to an acute leukemia for the CML patients, but we had limited systematic analysis of specific disease groups. And at the time we set our research question, there were still many unanswered questions related to these variants. So there'd been a number of labs around the world who had done some small studies, starting to find the same consistent mutations. But we didn't know what was the clinical relevance of these variants when we detected them at diagnosis of patients in the chronic phase. We didn't know whether some of the variants would confer a worse prognosis. And one of the really important things that we didn't know was whether a poor risk could be overcome with a treatment with more potent drugs. So these were the things that we wanted to find out by contributing to the Harmony platform. Yeah, so I'd say that there are many labs around the world that had performed these sequencing projects, and we were all looking for mutated genes, but we all had this small number of patients. And we know it's really difficult to answer the questions that I've just raised with a small number of samples. So we wanted to take advantage of the data that had been generated around the world by combining it together. So we know that the more data we have, the better our understanding of what these additional variants actually mean for patients in terms of response to therapy or their chance of developing drug resistance. So this was a great opportunity to combine our data. So as I've just mentioned, many data sets can strengthen the statistical power, and this can deepen our understanding of the clinical relevance of these additional variants. So that was the main thing, is that we could really build up the database. So these 468 patients that we've analysed actually comprise the largest cohort of CML patients that have ever been combined and analysed. So this is a really big thing that we've been able to achieve. Yeah, so enough really with these larger data sets, the combined data, we have been able to show that patients with an ASXL1 variant at the time of diagnosis are at an increased risk of treatment failure. So I think this is now really important additional information for risk stratification. But at this stage, we don't know what the best therapy for risk reduction is. It may be that combination of two BCR-ABL inhibitors would be beneficial, and there are some clinical trials in progress that are already using combined therapy for newly diagnosed chronic phase patients. But these are relatively small studies, and we don't have the outcome data for those studies. So I think at this stage, we can say that having an ASXL1 variant puts the patients at risk. And then I think it's important then that the clinicians follow the recommended monitoring frequency. I think this will be critical for patients with mutated ASXL1. And then intervention may be necessary, perhaps with a switch of BCR-ABL inhibitor when the patient, or if they develop drug resistance. So really, it's the same strategy for patients with and without mutated ASXL1 at this stage. Monitor really closely and just have a look at the residual leukemia. If it's declining, that's a good sign. But if it's not, then that could be a trigger for some intervention or even more frequent monitoring. And unfortunately, at this stage, there's no targeted therapy for mutated ASXL1, but this may be in the future. And I know that there are groups around the world who are looking at inhibiting this mutation because it's so common, not just in chronic myeloid leukemia, but in other acute leukemias as well. Yeah, so I think the collaboration has been really important for driving the project forward, because we've been looking for a long time to combine our data, and we couldn't find an appropriate platform. So the Harmony platform really solved a lot of the issues that we were going through. And there's also another ongoing collaborative project involving different CML patient cohorts. So I don't think that would have been possible unless we had this collaboration ongoing. And I think there's a few really important things in terms of ethics that had all been recognised as being very important by the Harmony Big Data project. So this was very important that we could get all of our ethical considerations in place. So we've got two projects working with Harmony. The other project is aiming to answer very different clinical questions, and these may ultimately benefit patients as well. So again, there are many advantages in pooling large patient cohort data to gain knowledge that just is not possible in individual small studies. So I think this is going to be really important for shaping the future of precision medicine. So far our major finding is the association of mutated ASXL1 at diagnosis in the chronic phase patients and the association with an increased risk of treatment failure. So this verifies data from smaller studies, and these studies have just recently been published. And in science, it's really important that someone else can perform a study and find the same results as others. So this builds trust in the reliability of the results. So although there is a smaller study that has recently been published and has found exactly the same thing, now we've been able to follow this up with this larger study of a single cohort being treated with the same inhibitor, and we've found the same findings. So I think that means that this data is very reliable. So we've actually got a lot more data on the Harmony platform that we haven't had an opportunity to combine with the current data yet. So that there's still a bit of work to do to combine that data. And then we will reanalyze the whole data set with an even greater number. We hope that we will have close to maybe 700 data sets from 700 patients, and then we'll be able to perform more sophisticated statistical analyses. So at that stage, we hope to publish our data, and ultimately our aim is to facilitate the incorporation of genomics-based algorithms into the clinical management of CML. But this has to be based on strong clinical evidence. So we're building this strong clinical evidence. And there's actually more data on the Harmony platform derived from CML patients, and these are from patients in a more advanced disease. So there's likely a different pattern of mutated genes in this cohort. So we haven't even started to analyse this data as yet. So there's still lots to do in this project, and we actually are really looking forward to looking at the patients in the advanced phases, because I think they'll have many more mutations. I'd like to say that it's been great working with the Harmony team over a number of years, and particularly over the last year as the data has really come together, and we've been able to work with some really important and very bright people working on this difficult platform sometimes, and we've had some great statisticians and bioinformaticians at our end. So I think it's been a great collaboration. So I think it's great that we've got to this stage, and we've got this ASH presentation that we're very excited to present the data.